Hello and welcome to a brand new episode of Pathways in Pediatrics, the official podcast of the European Academy of Pediatric Societies, EAPS. It is so great to have you with us.
It is. We are fresh off the heels of the recent APS Congress in Lisbon.
And what an event. It was quite frankly just a massive convergence of the best minds in our field.
It really was. And what stood out to me this year wasn't just, the sheer volume of data, but how the sessions were organized. We saw these overarching themes that cut right across the traditional tracks.
I noticed that too. You had neonatologists sitting next to general pediatricians, sitting next to researchers. It was fantastic.
Yeah.
And today we're going to focus entirely on one of those major themes, neonatal and early life care.
Which is such a critical area. And we're not just talking about surviving the NICU, we're looking at the entire trajectory.
Exactly. So we've curated a kind of journey through the key sessions that took us from the very first breath of life through metabolic adaptation into hemodynamic challenges.
And finally, looking at the long-term complexities of neurodevelopment. It's a journey from the acute mechanics of survival to the broader quality of life.
And we have a lot to cover, including some updates on resuscitation guidelines that might change your practice tomorrow.
And some truly surprising data on long COVID and autism that challenges a lot of our diagnostic assumptions.
So let's start at the very beginning. The delivery room. There was a vital session on guidelines and consensus featuring Barney Schofield and Erwin Rice.
Right. And Schofield was discussing the ILCOR 2025 updates, the International Liaison Committee on Resuscitation.
This was a crucial level set, wasn't it?
I think so. Schofield highlighted a frustration that I think resonates with everyone in pediatrics. It's the small adult problem.
Ah, yes.
He pointed out that despite all our progress, a significant chunk of our resuscitation evidence is still extrapolated from adult cardiac studies or animal models.
Which just leaves us with these really uncomfortable gaps. I know the debate on initial defibrillation doses is still ongoing, North America versus Europe.
And even the sequence of CPR. Breaths or compressions first. It feels like we should have definitive answers by now, but the pediatric-specific evidence base is thinner than we'd like.
That's the reality. But then Erwin Rice took the stage to talk about neonatal life support, or NLS.
And he proposed a shift that I found really, really powerful. It wasn't just about the technical steps, it was a mindset shift.
Okay.
He argued, we need to stop using the word resuscitation for the vast majority of newborns.
Because they aren't technically dead.
Exactly, they aren't in cardiac arrest. Rice suggested we frame it as supportive transition.
Supportive transition. I like that.
When you change the language, you move away from aggressive knee-jerk interventions and towards supporting the physiology as it comes online.
And the physiological anchor of that whole transition is the umbilical cord.
Absolutely. Rice was very specific about this. We aren't just talking about delayed clamping anymore, are we?
No, the terminology is shifting.
It's shifting to physiological-based cord clamping. A subtle but really important distinction. You aren't just watching a clock tick for 60 seconds.
Right.
You are stabilizing the instant-establishing aeration of the lungs while they are still attached to the placental circulation.
So you don't cut the old oxygen supply until the new system is fully operational.
Precisely. For preterm infants especially, that placental transfusion provides a hemodynamic buffer that can prevent a crash.
And he also talked about the human element, didn't he?
He did. Family presence. It's becoming the standard of care to have parents present even during resuscitation. It humanizes the process, and it reduces long-term trauma for the family.
But of course, it wouldn't be a medical congress without some technical debates. The oxygen concentration question came up again?
Oh, it always does. The pendulum is swinging there. For the tiniest preterms, the guidance seems to be leaning towards starting with higher oxygen concentrations, not lower, to avoid that initial hypoxic hit.
And what about airways?
The consensus seems to be moving away from immediate intubation. For many infants, a good bag mask technique or a supraglottic airway is just as effective and, frankly, less traumatic.
So let's assume we've managed that transition successfully. The lungs are aerated, cord is clamped, the baby's in the nursery. Now we hit the next major hurdle.
Energy.
The metabolic transition.
We're talking about glucose. The Paediatrics in Practice session. on neonatal hypoglycemia with Delphine Matanches and Emmanuel Monsignore was a real eye-opener.
I think hypoglycemia is one of those topics that causes a lot of anxiety because the protocols feel so rigid, but the physiology is actually quite fluid.
It is, and Delphine Matanches really challenged the fixation on the number 2.6.
Right, 2.6 millimolella, the magic threshold we all use.
But Matanches pointed out that the evidence linking asymptomatic transient hypoglycemia at that level to actual brain injury is surprisingly weak.
Really?
Yeah, it's low-quality evidence. Her point was we might be treating a number on a screen rather than the patient in the cot.
But the biggest takeaway for me was about dextrose gel. I feel like in the last few years, it's been hailed as the silver bullet.
Well, it is excellent for treatment. Matanches was very clear on that. If the sugar is low, use the gel. It keeps the baby out of the NICU and with the mother. But she strongly advised against using it for routine prophylaxis.
So don't just give it to every at-risk baby, just in case.
No, there's a signal in the data that prophylactic use might be associated with adverse neurodevelopmental outcomes later on. It interferes with the natural metabolic adaptation.
That is a crucial clinical pearl.
The message was clear. Treat the problem if it arises, but don't try to override the physiology preemptively.
So that covers the transient normal stuff. But then Emmanuel Monsignore put her endocrinologist hat on to tell us when to stop relaxing and start investigating.
Yes. If you are 48 hours in and the sugar is still low, or if you're having to pour in glucose, we're talking infusion rates higher than 12 milligrams per kilo per minute.
Then it's not transition anymore.
No. You have to stop thinking transition and start thinking hormones.
So we're looking for pituitary issues at that point.
We are. Cortisol deficiency, growth hormone deficiency. She listed the red flags to look for on the physical exam. Micropenis, midline defects, cholestasis.
Right. And if you see those...
You need to grab a critical sample of blood during the hypoglycemic event to catch the hormones while the sugar is low.
And then, on the far end of that severity spectrum, Indrain Banerjee gave a fascinating talk on congenital hyperinsulinism, or CHI.
The nightmare scenario.
Yeah, where the pancreas just ignores the blood sugar level entirely.
It is. And Banerjee showed data indicating up to a 50% risk of neurodevelopmental impairment in severe CHI cases. The brain is just starved of fuel.
And this is where we get into the genetics, right? Mutations in the KATP channels.
Exactly. Genes like ABCC8 or KCNJ11. But what I loved about this presentation was the precision medicine aspect. He talked about using PT scans to actually cure this.
That's incredible.
It is. If it's a focal form, meaning just one spot in the pancreas is malfunctioning, they can use an 18F-dopa PET scan to light it up.
And then the surgeons just go in and take it out.
They go in, remove just that tiny lesion, and the child is cured. No more meds.
Wow. But I assume if it's diffuse, affecting the whole pancreas, it's not that simple.
Not at all. Then you're reliant on medical management. Yeah. Diazoxide is the frontline drug, but Banerjee noted the side effects, particularly fluid retention and hypertrichosis.
The excessive hair growth.
Yeah. If that fails, you're looking at octreotide or newer therapies. But the key takeaway was urgency. You have to identify CHI early to protect the brain.
So we've secured the airway, we've stabilized the sugar. Now let's talk plumbing, the heart and lungs.
Yes, there was a really comprehensive session titled All You Need to Know About Pulmonary Hypertension.
A masterclass in hemodynamics.
It was. Rolf Berger started us off by just grounding us in definitions. Pulmonary hypertension, or PH, isn't a single disease. It's a condition defined by a mean pulmonary artery pressure greater than 20 mmHg.
But for us in pediatrics, the why matters more than the number.
Always. And for neonatologists, the why is often bronchopulmonary dysplasia, BPD, in those ex-preemies. Nidhi Varghese had a very specific recommendation here regarding screening.
She did. She advocated for universal screening echoes for all BPD infants at 34 to 36 weeks.
Which is so important. You cannot wait for clinical symptoms like failure to thrive or cyanosis. By the time you see those, the vascular remodeling in the lungs is already advanced. You have to go looking for it.
Then Olivia Danhave took us into the acute neonatal setting, PPUNCHN, using congenital diaphragmatic hernia, CDH, as the model.
Right, and he laid out a treatment algorithm, but he had a very specific warning that really stuck with me.
About the heart's interaction with the lungs.
Yes, don't flood the engine.
I remember that.
We instinctually want to use vasodilators, nitric oxide, sildenafil to open up the lungs, but Danhave warned that you must look at the left ventricle first.
Why is that?
Well, if the left heart is stiff or dysfunctional, and you suddenly open the floodgates from the lungs, the left heart can't handle the volume. You cause massive pulmonary edema, and the baby crashes.
So the algorithm is optimize the heart function first, then treat the lungs.
Correct. Start with oxygen and inhaled nitric oxide. If that fails, move to IV prostacyclin analogs like treprostinil. But always respect the left heart.
And Marie Spaghetti rounded out that session talking about the treat and repair strategy for congenital heart defects.
This is really the gray zone of cardiology. It's for those kids with holes in the heart who have developed such high pressures they're considered inoperable.
So you treat them with drugs to lower the pressure.
Just enough to make surgery possible. But Spaghetti was very, very cautious. If the pulmonary vessels are permanently damaged, closing that hole can be fatal. It requires incredibly precise catheterization data to make that call.
All right, let's zoom out. We've navigated the acute physiology of the NICU. But the early life theme at EAPS didn't stop at discharge.
No, it didn't. The final session we need to discuss was complexities in care, which really shifted the focus to the long game.
Unexplained symptoms, neurodiversity, and equity.
This was arguably the most impactful session for me. We started with Benjamin Baig discussing medically unexplained symptoms, specifically focusing on functional neurological disorder, or FND.
This is an area where I think we as a profession have historically struggled. We do an MRI, it's normal, and we tell the family there's nothing wrong.
Right, but the child is still paralyzed or having seizures. And Baig pushed back hard on that approach.
What did he suggest?
He described FND not as the patient faking it, but as a software problem. The hardware, the brain structure, the nerves is intact. But the predictive processing, the signaling, is glitching.
I love that analogy. You don't throw away a computer because of a bug in the code. You reprogram it.
Exactly. And the treatment is physiotherapy retraining the brain. But the most important step is the diagnosis itself. You have to give the family a positive diagnosis of FND.
Don't frame it as a diagnosis of exclusion.
Precisely. Saying it is FND validates the child's reality and opens the door to recovery.
Validation was a huge theme, which brings us to what might be the most surprising data set of the entire Congress.
I think so. Joshua Lee's presentation on long COVID and autism.
This came from the Evelina London Children's Hospital. They analyzed their pediatric long COVID clinic cohort, and the numbers were just staggering.
43% of the children presenting with long COVID had confirmed or suspected autism spectrum disorder.
43%. When the background prevalence is, what, 3% or less?
It's a massive, massive overrepresentation. But there was a twist in the demographics, wasn't there?
A significant one.
Usually, autism diagnoses skew heavily male. But in this long COVID group, the ratio was inverted. 60% were female.
That's fascinating. What's the hypothesis there? Why are we seeing this inversion?
Lee posed a few theories. One is biological. Are neurodivergent brains more susceptible to the neuroinflammation of long COVID?
Okay.
But the other theory is diagnostic overshadowing.
Meaning these girls were autistic all along, but they were masking it.
Exactly. They were high-functioning, coping, flying under the radar. But then the chronic fatigue and brain fog of long COVID stripped away their cognitive reserve. They lost the ability to mask, unmasking the underlying neurodivergence.
So long COVID is acting almost like a stress test for the neurodevelopmental system, revealing diagnoses we might have missed.
And it forces us to rethink how we treat these patients. We can't just treat the virus or the fatigue. We have to treat the neurodiverse child.
This connects directly to the final talk we want to highlight by Dimitri Christakis on intellectual and developmental disabilities.
IDD. It was a really sobering presentation. Christakis shared a statistic that everyone needs to hear.
Which was?
People with IDD have a life expectancy that is 10 to 20 years shorter than the general population.
That is a shocking gap. And that's not just because of their underlying medical conditions, is it?
No. That gap exists even when you control for comorbidities. It's because of us. The healthcare system, implicit bias, lack of access, providers speaking to the caregiver instead of the patient.
He called for inclusive health.
He did. He said it's a civil rights issue. He argued that we need to actively redesign our healthcare systems, from the clinic environment to how we communicate, to accommodate neurodiversity, universal dignity.
So if we look back at this whole journey we've taken today, we started with the mechanics of a first breath in the delivery room.
Moved through the biochemistry of sugar, the hemodynamics of the heart, and ended up at the societal structure of inclusive care.
It's a wide spectrum, but there's a common thread, isn't there?
I think so. I think it's the convergence of precision and empathy.
How so?
Well, in the NSEU, we need extreme precision genetic testing for CHI, targeted echoes for pH, specific algorithms for resuscitation. We need to know exactly what is breaking biologically.
But that precision isn't enough on its own.
No, because as we move to the long term, to FND, to autism, to IDD, that precision has to be wrapped in empathy. We need to understand the human being inside the physiology.
We need the PE scan and the inclusive policy.
We need to stop treating the small adult and start treating the developing human with all the complexity that entails.
And that is what EAPS does so well. It brings those two worlds together, the hard science and the human art of pediatrics.
I think that's the perfect place to leave it for this episode. It's just amazing how much ground was covered in Lisbon, and we've only really scratched the surface of this theme.
It was a standout congress.
It was. And the conversation doesn't stop here. The research moves fast, and we'll be keeping a close eye on how these guidelines evolve.
We want to thank you for joining us on this episode of Pathways in Pediatrics. We really hope this overview gave you some actionable insights to take back to your wards and clinics.
And we are already looking ahead to the next time we can all gather in person.
That's right. The conversation continues at the next EAPS Congress. We will be heading to the historic city of Athens.
Mark your calendars.
24th to the 27th of September, 2026.
Athens, 2026. I'm already looking forward to it. Until then, keep asking questions, keep learning, and keep advocating for your patients.
Thanks for listening, everyone. Take care.